Welcome, everyone. Thanks so much for joining us today. You are here for the Funfetti approach to SDOH screening. This is not a cooking class. For those of you who don't know what the Funfetti approach is, you will soon learn by the end of this webinar. My name is Natalie Graves. I'm the Director of Research and Implementation at Convergence, and thrilled to be here today co-hosting this webinar with PFCC partners. And we are here today to talk about working with patients and family caregivers as partners in all of the pieces of the SDOH screening process, from thinking about how to set up that screening process in your facility and all the way to then figuring out what to do about the needs for your individual patients and needs in your community as a whole. Now, if you've joined our sessions before, you might know that we always encourage the audience to ask questions or share your reactions or your ideas in the chat with us. And I want to really double down on that invitation or request today. So please do add your questions or ideas or reactions in the chat throughout, and don't hold back. Bring the tough questions too, because we have a really thoughtful and experienced panel today who I know is game for those tough questions as we get into the conversation. So I'm going to get us started with an overview of what we're hoping to accomplish today. So we have a lot of these sessions on all different aspects of SDOH screening. If you are new to that and hoping to learn more about kind of the technical details, I can absolutely point you to some other resources after today. But what we're hoping to focus on today is how do we actually partner with patients and family caregivers and community members to set up these processes to both screen for and then address social drivers of health. And so today, through a conversation, we're going to focus on things like sharing specific ideas and examples of how hospitals or different facilities are doing that. We'll talk a bit about the importance of working with stakeholders or partners outside of the hospital, right? So those community-based organizations or other formal or informal networks in your community that can help meet these needs. And then we'll spend a lot of time talking about this idea of how do we build infrastructure or processes or ongoing strategies to learn as we start to implement these programs. So this is not something that will be stood up in your EHR one day and then you'll check the box and move on. All of the work around thinking about and meeting social drivers of health needs is something that we'll continue to learn about and evolve probably forever. So we'll talk about how to set up systematic ways to learn and then improve our process. So we'll get started with some introductions. I want to start with introductions of our panel. But while we're doing that, I also would love to hear who's in the room with us today. So if you could share in the chat your name, the facility you're with, and then or organization you're with, and then a little bit about why SDOH screening or thinking about social drivers of health matters to you. And why this is important and why we're curious to learn this is because we actually hear that this is a really big challenge, that there are many people who are coming to the table to stand up these screening processes, especially in hospitals. And we don't always have great ways of explaining to people who are newer to the work why it's important. So I would love to hear why this matters to you, what motivates you to do this work. And while we're doing that in the chat, we'll go ahead and introduce our panelists. So as I said, my name is Natalie Graves. I'm with Convergence, and our mission at Convergence is to accelerate improvement in healthcare. Lindsay, I'll turn it over to you to introduce yourself, and then Barbara and Laura, and then I can go to your PFCC partner slide too if you want me to do that now or in a minute. Just give me the cue.
Sure. If you just want to go there now, I'll introduce our organization while I'm at it. Hi, everyone. Great to be with you today. I'm Lindsay Galley. I'm the Vice President of Programs at PFCC Partners, coming to you live from sunny, finally, Sacramento, California. PFCC Partners, we have a mission to center the inclusive human experience of health by reinventing through radical collaboration to really be that catalyst for system transformation. And we have a vision that I think we share with many, a health system that is transformed and one that works with people and through communities as a partner in their well-being. So I think throughout today's session, you'll see that vision come to life, and that is our organizations. Why? And I will pass it to Barbara.
Hi, everybody. I'm a volunteer patient family advisor, and I do this in many different forms. I am a PFA at Sutter Health in Northern California, where I am on the board of directors for their value-based network, and I'm on their Social Drivers of Health Executive Steering Committee, on their Chiefs of Staff Council, and work in several other areas having to do with quality and safety. At the state level, I'm on a technical advisory panel for California Health Compares, and at the national level, I'm on panels with CMS, NIH, NIA, AHRQ, PCORI, and 5 or 6 other acronyms that I don't even remember. And I do this, and I've been doing this for about 7, 8 years. I do this because I live with a chronic pain condition, and it took 10 years to find a treatment approach that worked, but I'm a lucky one. I have a life and I'm doing okay. So I have a huge karmic debt to pay back. And this is how I do it. And I can't think of anything more meaningful and purposeful than serving you all, serving the people who take such good care of us in as many ways as possible. So I guess I'm turning it over to Laura.
Yeah, that works. Thanks, Barbara.
Thank you, Barbara. Hi, everybody. Good afternoon. Thank you so much for sharing time with us today. My name is Laura Carroll. I am talking to you today from a small rural community nestled on the western slope of Colorado. We are just getting into agricultural season around here. We're pretty excited and busy, that's for sure. Why I got into this line of work. I got into this line of work because I believe that sustainable change happens when stakeholders, all stakeholders, have a seat at the table. You, me, everybody. And the only way that we do that is we find people with willing voices to come forward, and I have a voice that is willing. I started off doing patient experience work in Denver, where I actually served on the Member Experience Advisory Council for Health First Colorado. It's our Medicaid branch out here. And it really taught me the importance of stakeholder engagement. When several years later, I decided to move to the country, and I really thought I was going to be retiring from this line of work. But once you get into rural America and you really see what healthcare looks like in communities like mine, you can't stay quiet. I tell people in rural America, I always write it down so I say it in the right order. We are older, we are sicker, we are poorer than suburban and urban populations in this country. 74% of my community is on Medicare, Medicaid, or both. 52% of my community qualifies for free and reduced lunch. It is a completely different environment with completely different access to healthcare. When I realized that access was actually a pretty funny word in rural America, because I don't get to choose my cardiologist, I get a cardiologist and they're 2 hours away. So the longer I stayed in rural America, the longer I realized that I needed to bring a voice to the table. So I'm active in several different patient-family partnerships. I sit on the one with Convergence, of course. I also sit on a patient-family advisor forum with Curus Health based out of Massachusetts. I am also the first ever patient voice on the Member Services Board for the state of Colorado. We approve all rules for Colorado Medicaid. I'm so thankful to be here and talk about social drivers of health, my favorite geeky topic ever. Thank you.
Wonderful. Thank you. All right. So another call. If you have questions, put them in the chat. As you can see, we have real experts here today. So we have a lot lined up for today, but we are, always happy to add those questions in as well. And thank you for putting all your introductions in the chat as well. I love seeing folks from research and in the hospital and patient family advisors as well. So thanks for doing that. So I wanted to start with an acknowledgement that this work is hard. And you all know this, right? You're doing this day in and day out, but we have these conversations with hospitals all across the country. And I wanted to just kind of set the stage with some of the most common challenges that we're hearing. And you may have these challenges. And so if you do, certainly know that you're not the only one. And if you are coming to this from a different perspective, maybe you'll learn something new about some of the common challenges that folks are having, particularly in rural communities. So I put these in a couple different buckets. The first is helping staff to understand why we're doing this work. So I referenced this already a little bit. And there's a lot of different pieces to this, I think. On the one hand, we're hearing that sometimes the folks who are doing the screening, whether they have a nursing background or perhaps they're medical assistants or perhaps they're wearing other hats in those smaller hospitals, they don't always have the academic understanding or background or education on how these social drivers of health actually relate to the care that they're providing in the hospital. So we have to take the time to make sure we're explaining that and understanding how it's relevant. There's also, of course, the technical piece that people have to understand, that in addition to asking the questions in a way that's sensitive and having conversations that engender trust with our patients and making sure we can connect them to resources, we also then have to document this, right? So that all of those data pieces and requirements can be met. And that's a whole different set of skills to learn. So there's a lot of work to do around helping staff to feel prepared and comfortable having these conversations with patients. The second challenge we hear a lot about is now that folks are starting to gather this information, have conversations, and document that, what do we then do with that data or that information? What do we do on a one-on-one basis with patients? And then what can we do when we step back and say, wow, we have this great need in our community, and we don't right now have a resource. What can we do about that moving forward? So that gets us to the third bucket. When we identify these resources, what do we then do about it? One of the things we can do, one of the places that many organizations start, is by thinking about ways that they can connect patients to resources. So maybe those resources exist in your community and it's a new process for you to know how to give that information out to patients, whether that's through some kind of resource guide or a link or an active referral. Maybe those resources don't exist in your community, right? And so this is one way of thinking about what you can do, but there are lots of other ways to think about how to take action to meet those needs. And that's really going to be the focus of our conversation today. And then, of course, there are all those technical details to think about. How do you get this set up in your EHR? What are the workflows? Who is asking the questions and when? And we'll also spend some time the second half of today talking about how patient and family partners can also help you think through those technical pieces of the process to, again, have it be one where staff feel equipped and patients feel comfortable and understand why we're asking and what can be done, what we'll do with the information. So the biggest challenge we hear from the patient perspective and also from the hospital perspective is actually the same. And that question or challenge is, why are we asking these questions if we can't do anything about it? Or what do I do if I'm asking these questions and we can't do anything about it? Maybe I, as an individual asking, can't do anything about it. Or we feel like even as an institution, we can't do things about these really big challenges like housing. Maybe you just don't have enough housing or affordable housing in your community. What am I as a nurse supposed to do? Or what am I even as a hospital supposed to do? And that, I think, is the question, right? There's no easy answer to that. If there was an answer, we wouldn't be having this conversation. But now that we're asking, the cat's kind of out of the bag, right? And so this is my cat. I don't know why they have that expression, cat's out of the bag, because my cats are always in bags. But now the cat is out of the bag. Now we're seeing, we have information, we're having conversations with our patients. It's not some abstract data on some county dashboard, or it's not something that we can explain away and say, yes, we have that need, but it's not our patients. Now we can really see what our patients are coming to us with and struggling with and need help with. And so our charge is to figure out how to do something about that. And so there are a lot of ways to go about taking action. And what we think of as the secret sauce at Convergence and PFCC partners is that we need to do that with patients, with family caregivers, with people in our community who have the lived experiences that can inform the changes we make and the resources we offer. So this is one kind of simplistic way of thinking about if you're a hospital and you're saying, okay, we know we have needs in our community, but what can we do? Where can we start? this is kind of a simple stepwise approach to think about actions you can take. On the one hand, maybe you're at the point where you're asking these questions, but you're not doing anything about it. And that might be because you don't have resources in your community, or maybe there are resources, but you don't yet know about them. And maybe it's obvious to say this is not ideal, right? Put yourself in the shoes of a patient. Maybe most of you have been asked these questions as a patient. If someone asks you these questions and then doesn't do anything about it, that's not great, right? So we want to move beyond this as quickly as possible. There's lots of work going on in terms of developing resource guides or giving information to patients who can then follow up and access those resources. Some organizations are more actively referring patients to different organizations. And then there's this future state where perhaps now that we identify a need, we can come together with others in the community and actually create something new. So again, really simplistic, but there are a couple complicated things to think about as you start to think about how to take action, how to design your approach. And the first is, what information and data is actually guiding your action? Maybe it's the screening data. Maybe it's your understanding of what exists in your community. Maybe you're going on Google or on Find Help or some of these compilations of resources that exist, and that's what you're pulling in. So you might have a lot of data, but also think about, what do you not have, right? What exists out there that you're not yet aware of, and how can you gain access to that information? And the second piece is, who takes action? SDOH screening, we talk a lot about how it's a process where we need to involve multidisciplinary, interdisciplinary teams, both inside the hospital or inside the healthcare facility, and then externally as well. So it might be your nurses or your social workers who are screening patients or having these questions during the hospital stay, but it might be some kind of population health group who's thinking about how to invest resources. And it might be these external organizations who you don't even yet have a relationship with, who can actually help patients meet those needs. And so all of this means that we have to communicate and we have to learn together. And one of the ways that we think about that here at Convergence and PFCC Partners is, how can we create these information flows between the individual screening process and having these conversations with individual patients? How does that help us understand what needs exist also in our community on a larger scale? And then once we start to understand what exists in the community, then we can connect those back to our individual patients. And so all of this is really a big loop. And we want to think about ways that we can, again, build those structures and information flows so that we're continuously learning and connecting those dots. Laura, I wonder if I could just pause here and see if you have any reflections or could illustrate how this might work, how something like this has worked in your community, the relationship between, someone's individual needs, and then also how we can learn about from patients and families what exists in the community so that we can better meet those needs.
We're dealing with a lot of that right now in our county. I'm in Delta County, Colorado. We recently had a situation, unfortunately, where our only major mental health provider was shut down by the state. And I don't think we really realized how serious of a situation this was until we started seeing the uptick in the emergency room, right? People not being able to get the things they needed to properly function. What was really cool in Delta County and Delta Health really stepped up to the plate on this one as they started seeing more and more and more people coming in mental health crisis. Even though we are a small rural hospital that barely has all the tools that we need, they've decided to redouble down on a mental health department within Delta Health. They were able to get some pretty quick emergency grants and do some other work. And really the only reason they were able to do that is because they were adequately screening for social drivers of help. And they were seeing people over and over saying, I need mental health, I can't get to it. I need mental health, I can't get to it. I need mental health, I can't get to it. And that gave them the opportunity to go talk to other organizations and create these paths. It's really important in these small rural communities. We do a lot of it for ourselves out here. I tell people stories about how we all do our part. I have a box of food that sits in front of my house, and people in my community know if they need food that there's a box of food in front of my house. And they know where my house is. And a lot of these resources are going in through the hospitals and through our healthcare systems and being dispersed back out into the community where we look after our own. It's very powerful here.
Thanks for sharing that. So another way to think about this work, again, I mentioned a lot of the times we think, if I ask, I have to have a solution. I have to have a direct solution, right? And that's wonderful if you can. If someone says they have a need and you're able to meet that need in the moment, that's excellent. But that's not, we're never going to be able to do that for 100% of our patients. Even if we have a robust network of community resources and social services, there will still be needs that are challenging to meet. And so I want to offer this 5 A's framework, which comes from the National Academy of Medicine, as a way to kind of shift our thinking of how we can take action to meet these needs as we start to learn more about them. And what I like about this is that it doesn't necessarily, it doesn't keep us in the box of thinking one-to-one, but helps us kind of step back and think, are there ways that we can adjust as a healthcare system the way we operate to anticipate or mitigate some of those challenges people are facing? Are there people we can partner with? Are there ways we could share information that then empowers others to act differently? And so there are 5 A's, which is also easy to remember. I'll just kind of briefly walk through each of them. Awareness, that's what we're doing with the screening, right? That's the cat in or out of the bag. So now we know, we have more of an understanding of what people are facing. And of course, by asking the set of questions you ask, whether it's 5 or 20, that still only gives us the beginning of an understanding, right? We're still only getting some pieces of what people are facing, and also only some understanding of the resources that people actually have to meet those challenges, right? So we're still at the beginning of developing our awareness as individuals and as a system of what the true needs are. The second one, adjustment, I really like, because it's something that we as healthcare facilities can think about doing even in the absence of other resources in our community. So I'm going to steal the example that the PFCC Partners team always uses, and I might get it a little bit wrong, so correct me if I do. But there's a story about working with a healthcare system or a clinic who kept seeing patients come late. They were missing their appointments. They were showing up, pretty late to their appointments. And they started asking people, what was going on, and they realized that a lot of these folks were taking the bus. And what they realized is that the bus station was pretty far from the clinic. And so people were taking the bus, but then they had to walk a great distance, or perhaps the bus wasn't always 100% reliable. And so these folks were missing their appointments or showing up late. And so what that clinic did is they actually worked with the Department of Transportation in their community to move the bus stop, or to get another bus stop put in right in front of the clinic. And then people stopped showing up late for their appointments, right? So you actually move the whole bus stop instead of saying, putting it on the patients who were already relying on this form of transportation to figure out how to adjust. And that solved the challenge, not just for one patient at a time, but for a whole group of people who were using that resource. Number 3 is the more classic way that I think we looked at this. How can we provide assistance directly to patients? If they say they need help getting food, is there a food pantry in the area we can connect them to? Are we able to offer some kind of bags of food, which I know a lot of organizations have programs to do that. Alignment is thinking about who are the other people in our community who are working on these challenges, right? There are, even in small communities, I work with a lot of small communities, and I am always shocked and humbled by the expertise that exists in all different areas. There are people who care and who have great expertise in your communities, even if you don't know them yet. And how can you find those people and then work collectively to garner those resources and focus on a challenge? And then advocacy is more upstream. What can your organization do as a pillar in your community, as an anchor institution in your community to affect change? Laura, I'll go back to you, and Barbara as well. What are your reflections on this kind of different way of thinking about addressing social drivers? How do you think this helps us think more broadly about what healthcare organizations can do to start to meet some of these needs?
Thanks again, Natalie. You'll hear me say over and over and over, it's about the why, it's about the why, it's about the why. And the 5 A's give us the why. What I like about this is it's also a tool that is helpful when you are speaking to patients and going over those social drivers of health in your in clinical settings. In our community, doing social driver of health screenings is some dicey business because sometimes the person doing your social drivers of health is also your kid's school teacher during the week, but picks up RN shifts on the weekend. It's not unusual for your next door neighbor to be the person to be doing your intake. There's a lot of HIPAA that flies out the window when everybody knows everybody in the environment, and it causes a lot of apprehension within your community. What I really like about this, and I've actually tried it out with some people who have been asked the questions and been concerned, is I think you turn these 5As right back to your community members, because I can tell you in my rural community, we want better. We want more. And if we understand why you're asking personal questions about us, we will spill our guts all over the floor if you're telling us that you will bring us the help we need. I would encourage, again, as you go through your social drivers of health screening program, whatever that looks like, don't be afraid to share with the patients why you're collecting this information and how it's going to benefit the community as a whole. That is very important. Thank you.
Thanks. Barbara, what would you add?
Laura's just so wonderfully knowledgeable and articulate. It's hard to think of what else to add. But what stands out for me about this model is that I think typically healthcare tends to be very hospital-centric, very bricks and mortar hospital-centric. You know, patients go to the hospital. And sometimes, as Laura pointed out, just getting to the hospital already touches on several social drivers of health. But what this does, and what a focus on social drivers of health does, is it stretches the hospital away from being just bricks and mortar and focus to a focus on patients as a stepping stone to a focus on community, which I believe is where strength and health live. And I think the more that the system, the healthcare system, the building, the hospital can not just make connections in the community, but strengthen the resources that already exist in the community, is very, very powerful. I'm on the board of an organization called Community Living Campaign. And one of the areas that we have become aware of that isn't per se a social drivers of health, but it underlies it, is the great technical divide, you know, between those who have easy access to internet and to devices and those who either don't have access or don't know how to use it, or don't speak English. So we understand that this is in San Francisco, that's a large percentage of the population, whether it's Asian or Latino. And so we now have a program that teaches technical literacy to this population. And what I'm hoping to introduce is a focus on healthcare technical literacy, you know, how to use your My Health Online, how to use My Chart, how to use Find Help, how to use, you know, other healthcare programs. So the shift from bricks and mortar hospital, you come to us, to understanding the patient and the pressures on the patient, to understanding the patient's existence in the community and what supports already exist in the community and what supports are needed in the community. It's a very powerful flow and an important one.
Thank you. So I'm going to turn it over to Lindsay here next. But what we like to do, what we want to do, what we want to encourage all of you to do as well, is to work with your patient and family caregivers and other members of your community, people with lived experience, to go from looking at the data. We like to say the data tells us what to focus on, right? You can look at your screening data, you can create a simple graph that tells you where you might have the most need, or maybe in what zip code you might have the most need. And often our inclination, especially those of us who want to help, right? We can see this is what the issue is. We want to help. Sometimes we go too quickly to action, right? And we make too many assumptions, and we don't take the time to really understand why that need exists, why that gap exists. And the way that we can bridge that gap from going from the data telling us what to do to figuring out the most effective and efficient way to actually take action and meet that challenge is to spend this time focusing on the why. And the way we can better understand the why is by talking with people, right? We can talk with our patients, our family caregivers, our neighbors, the people that we interact with every day. We also need to talk with the clinicians in our facility who also have an understanding of what's going on, some of the barriers that they're facing, or some of the barriers that they see patients facing. And so what we'll spend the second half of the conversation today really digging into is how you can do that, how you can actually have these conversations when you're so busy and it can feel difficult to figure out, I want to do this, but how do I actually start to work with my patient and family partners? We're going to talk through some examples of how to do that. So Lindsay, I'll turn it over to you to continue the conversation.
Yeah, thanks so much, Natalie, for kind of gearing us up for this next half of the session. And I think, you know, both Laura and Barbara, you've done such a good job of emphasizing the why. And also Natalie, you know, looking at those shared challenges that we started with, you know, those shared challenges are shared amongst, you know, hospital staff, clinicians, but like it was mentioned, also shared with patients and family caregivers and the community, you know. So bringing all of these people together to identify the why behind the data will then help you get to a place where you can together define the how. And I know we have some great examples of, you know, how data has been used to bridge into action. And Barbara, I know you had shared a really great example of how data has highlighted needed community resources, specifically in San Francisco. So I'd love if you could share that example.
Yes, so among the well, there are several populations of need in San Francisco, and one of them certainly is older adults. And the local hospital, which is a Sutter hospital, has an acute care for the elderly unit, seeing people 65 and older. And what was happening is what's happening everywhere. People would be treated, discharged, and within 30 days, they would wind up back in the hospital. Or within 30 to 60 days, they would wind up in the emergency room. And this revolving door was not only dreadful for patients and families, it was very costly to the hospital. And what they learned is that one of the biggest whys for why this was happening is that patients weren't able to get transportation to their first follow-up doctor's appointment. They weren't able to get their medication, and they weren't able to have a healthy and regular food supply. So there's an organization in San Francisco called San Francisco Village, and I was on the board of that organization. And what San Francisco Village does is it provides for all those issues. It provides for the social drivers of health. It provides volunteers who will remind patients to take their medication, will pick them up and take them to their doctor's appointment, and will go for walks with them, will play chess with them, will become friends with them to break down another key driver of illness, which is social isolation. So a program developed where the hospital would refer discharged eligible patients to San Francisco Village and pay for a 3-month membership, which was not very costly at all. But they would pay for a 3-month membership for these individuals. And they were, once they stepped foot in the door of San Francisco Village, they were immediately connected with services and volunteers and resources on a consistent and regular basis. And very importantly, they met other individuals who were going through similar things to what they were going through. And they were exposed to a range of classes that provided intellectual and physical stimulation. So the result was wonderful. The result was that the number of patients who were readmitted within 30 days or had an EW visit dropped surprisingly low. And the program is now being expanded through this hospital system.
That's amazing. I love when you find the resource in the community, you know, led by the community as well, that directly impacts outcomes of patients, people, everyone. I think that's such a great example. I also know that there are more informal resources within the community as well. I was talking to another patient family advisor. I believe he lives in Washington, somewhere in the upper Northwest. And he was just telling me about his weekend. He said, "Oh, yeah, I had to drive so-and-so to their doctor's appointment." And I was like, "Oh." And I said, "How did you get into doing that?" He said, "Well, I offered to drive one person to their doctor's appointment because they didn't have transportation, and then word spread, and now everybody's calling me for a ride." And I just thought that was amazing. And I know that there are so many more informal resources like that as well, that, you know, when aligned with amazing resources like San Francisco Village and other community resources, can really bolster the support that patients and family caregivers get. And I know, Laura, you had mentioned briefly just a little bit ago about how that looks a little bit different in a rural setting. I wanted to see if you wanted to add anything else there.
Well, I mean, you know, kind of, I feel like I knocked all of that out.
Yeah.
Really, it's all about the why. It's all about the why. And we keep coming back to that. And I got to be honest with you, that's no different at Denver Health than it is at our tiny little rural hospital. We just got to keep harping on the whys. And as we keep harping on the whys, I think that's where resources start to bubble up, right? I mean, you know, if you start to see all these reasons why we're doing this, and then you start to see the patterns as people start to open up, it creates opportunity to either find or create these resources, right? And that's especially in these smaller communities where it's all so grassroots driven. I mean, there's real power in that.
Yeah, absolutely. And I think that goes back to the 5 A's, the first one being awareness, you know, awareness, of course, in that clinical setting, but awareness for patients, family caregivers, the entire community, because those sparks of those individuals who are doing their own thing, helping their people, can really be highlighted and grow. I like that. All right. Natalie, can you go to the next slide? So on that note, I have a question for everyone. If you could put in the chat, what is the most underutilized resource in the healthcare environment? A little pop quiz, if you will. Oh, I gotta open my chat. You can come off mute and share too. What's the most underutilized resource? Barbara says the family caregiver. Holly, each other, families, the patient perspective, the patient. Yes, you are all right. A+ all around. Patients, family caregivers, the community. Laura, I love that. Our ears. We do a lot of listening around here too, and I feel like that the whole 5 A's too, and what we're going to go into right now. It's about listening and identifying that why that we're all talking about. I see community health workers, community. Awesome. Natalie, if you could go to the next slide. one more. Yes. Oh, one back. There we go. So yes, that you all got an A+ on that quick pop quiz. But it's patient family partners. And so this is the more formal role of people using their lived experience to transform healthcare together. So Laura, Barbara, myself, I identify as a patient family partner. We have a lot of other patient family partners on as well. But also, like we were talking about, those informal partners within the community that haven't yet been identified, one of the most underutilized resources. So how can we engage those perspectives in how your hospitals are developing your social drivers of health screening programs? So on the next slide, we have calling this the lanes of engagement. So I think for a long time, a lot of healthcare organizations had been really focused on patient family advisory councils, PFACs. Over the past few years, we have recognized that there is a need to open more doors in more places in the community in order to hear the perspectives that have traditionally been underrepresented in engagement work. And so this chart really outlines, the different activities. Something as simple as a survey, using patient portals, even hard paper copies, or informal staff encounters to gather information and perspectives from people with lived experiences. And it goes down, interviews, focus groups, listening sessions, engaging a person with lived experience directly into a quality improvement initiative or on a quality committee, or even a committee who is working solely on the development of your social drivers of health screening programs. Can you identify someone to be that thought partner from the person with lived experience perspective? And then, of course, patient family advisory councils, patient family partnership councils are a true resource within hospitals and healthcare organizations, that is really hardwired into how those healthcare organizations operate to engage the patient and family perspective. But you can see, so with each of these activities, recruitment looks a little bit different. The preparation for each of these activities looks a little different, as well as the level of commitment by the patient family partner, and then the level of effort that is required by staff as well. So we'll share these lanes of engagement out in follow-up. So as you move forward in thinking through how you would like to engage that lived experience perspective in the development of your social drivers of health screening programs, you can use this as a guide, so maybe as staff, the level of resource that you have to offer is a little bit low. So maybe you can start with some interviews. Maybe you can invite some patients and family caregivers who have some relevant lived experience to help inform the processes that you are developing. So we will share that out in follow-up, but I'm kind of curious if there are any hospitals on, any clinicians or hospital staff who are currently partnering with patient family partners on social drivers of health screening implementation or developing processes around that. Joanna, still in the planning phase. Well, that's a good place to be. You're in the right place.
Yeah, I was just going to jump in and say, Lindsay, I've talked with a couple folks recently who have said exactly that, Joanna, that they're in the planning phase. I talked with a hospital who was preparing to bring their preliminary SDOH screening data to their PFAC. So would love to hear from anyone who's even planning to, and what planning looks like, or what the challenges are.
Yeah, challenges are what you may need to support those next steps. Yeah, Barbara, I see your hand up.
Yeah, I can give an example from the patient family partner side of how I've been involved. So at Sutter Health, they are now screening everyone 18 years and up, asking them SDOH questions and some other questions. And they were creating scripts for the people who were going to be asking these questions. Could be doctors, could be nurses, could be the people who sign you in, could be online, could be in your text. And the scripts that they originally came up with were very clinical, speaking mostly about the benefit to the hospital. And I was invited to be on the team that was working on these scripts. And so I took my red pen and went through the scripts and made them simpler, made them much more patient focused, and showing the benefit to the patient and to the patient's community. So that's just one example.
No, that's a great example. And, you know, how much more lean would that be if they brought you in while they were creating the script, you know? So they didn't have to go back and make those edits. I think that's why I'm so excited to see that there are so many people on who are in that planning phase, because now's the time to gain that perspective so you don't have to go back. But I love that. I think that's a great place to start the development of that scripting, the language that is used. That's a great example. Thank you, Barbara. And I see some others. Holly says that they've added questions to also find out the strengths of families. I like that, using strength-based language. And Joanna, currently doing surveys. That's awesome, but still trying to plan out what to do next. Well, hopefully you'll walk away with a few additional ideas of where to go from here. And yes, Libby shares patient family engagement. It's all about working smarter, not harder. Yeah, get all of that information that you need from the start. We recently were talking to hospitals about the development of their patient family partnership programs, and Libby had shared a video of someone who tied a lawnmower to a tree, and it just went around in a circle and mowed the lawn without without anybody standing there and pushing it. So talk about working smarter, not harder. I like that a lot. Great. Well, great ideas. And, you know, we have this chart as a resource. Oh, thank you, Holly, for sharing. Our team also employs family representatives and partners with families, family to family and patient representative groups. That's awesome. I love seeing that. We have this lanes of engagement as a resource. We are also resources to your hospitals. We have a lot of other resources that we could share with you. We have an interview guide that is specific for readmissions, but the concepts behind how to prepare for an interview and the types of questions that you ask can really come into play with any topic, including social drivers of health implementation as well. Yeah, Beverly?
I don't know if rural hospitals have them, but in Indianapolis, some of the hospitals actually have a rehab center with them, or a home care agency that's attached to them, or, you know, that's a part of the system. And I'm wondering if that may be a way for them to get information, or to partner with them to get more information, or work with them in any way they can to get, you know, their surveys out, or some more data,
Right.
or, you know, interviews or whatever. But I imagine the folks that come in for home care that are attached to those hospitals are getting a lot more information than they may get from a survey, just sending out a survey.
Right. Yeah, absolutely. I appreciate that idea, Beverly, and it actually brings us into our next topic, our last one for the day as we're wrapping up. So I wanted to bring this slide back just because I love how it illustrates, the fact that screening informs individual needs, which informs the needs within the community as well. And there are, so many individuals inside of the healthcare organizations, but also externally that, we may not be thinking about yet um, who can be leveraged to address social drivers of health within the community. As we've heard today, all communities have assets that can be leveraged to address social drivers of health. I'll go to Laura first. I'm curious your thoughts about how people with lived experience like yourself can help hospitals understand where and what those resources within the community are.
Thanks, I appreciate it, Lindsay. It's the talking, it's the listening, it's the talking, it's the listening. It's that constant drive. It's a drive that comes from making sure that our communities have the things that they need in order to thrive. And the whole point of social drivers of health is that our communities will thrive once they have all the things that they need to keep their bodies and their minds and their socioeconomic environment healthy, strong, and thriving, right? We do that by engaging community, which is a group of individuals. We lift people up. We bring them to the next level with us so that they can be stronger and we can move forward together, especially in our smaller communities where we all wear 100 hats. I love the social drivers of health as a tool to heal communities. I really love the idea that we cannot fix what is ailing our communities unless we start asking the people who live in those communities. So I love that this is the direction that social drivers of health are going. I love that we're having these big, rich conversations about how it's not just about the person who's sharing that information. I'm so excited to see this many people wanting to talk about it. Like, this is just, it's just such a great first step. This is so exciting. I can't wait. I can't wait till we work ourselves out of a job, Lindsay. That's what I'm
right. That's what we're all trying to do.
Right.
I really appreciate that, Laura. That's an amazing perspective, through social drivers of health screening and addressing them and listening to the community needs and identifying those community resources, we can help heal the community. I think that's beautifully said. Barbara, I'm going to get to you in just a minute. I just want to prompt everyone else on to start thinking through who are some of those external stakeholders for addressing social drivers of health, whether it's community-based organizations, churches, schools, food pantries, some of those informal community connectors that we had briefly talked about today as well. Would love to see in the chat, and thinking about your own communities, where are some of those external stakeholders, some of those assets that you can start connecting with? So please put those in the chat. And yes, Barbara, I have the same question for you. I think you had a great example earlier, but how can people with lived experiences continue to help hospitals understand the resources within the community, and then anything else you wanted to share?
I think there are two big challenges that come up when hospitals start to construct their SDOH initiatives. One is that people feel like they're invading somebody's privacy, or they're asking questions that are uncomfortable and intrusive. And I'd like to take that and reframe it. These are not intrusive questions, and this is not an interrogation to get data. This is about having a deeply caring conversation to truly understand your patient as a whole person, and to understand the strengths that they bring and also the areas where they have holes in their lives. So it's about having an empathic, caring conversation, which is an opportunity to build deeper relationships with your patients. And your patients have been living in the community for their entire lives. They know to go to Laura, what to get that box of food, from the front of her house. They know a lot about what exists in their environment because they've been living in it. And if they're still alive, then they've been using things effectively. So asking patients, asking the patient, who do you go to for? How do you manage your transportation? Your story, Lindsay, about the guy who's the driver. Who do you go to for? I think is a critical question when you are doing a social drivers of health caring conversation. And that's how you learn about resources in the community.
Yeah, absolutely. It's not a yes or no. It's diving deeper to learn more. Well said. Thank you, Barbara. I see Beverly has added senior living and assistant living facilities, home care agencies are often recruiting for services while providing social activities for seniors as well. Thank you for sharing that, Beverly. And yes, just encourage you all to start thinking through who are some of those more external stakeholders that you haven't tapped into, and can you reach out to listen and just start having these conversations and just start asking those questions and creating connections within the community. All right, I know we have just a few minutes left, so Natalie, do you want to go to the last slide, or did you have any other questions for the group?
I don't have any other questions, but I wonder if anyone on the line does. Anybody on the line want to? You're probably going to do that. Ask a question to anyone or the group. While people are maybe typing or finding the mute button. Lindsay, can you remind us where folks can go if they want to learn more about those different patient-family engagement resources you mentioned, or have the opportunity to talk more with us? Obviously, you can email either of us, but Lindsay, tell us more where people can go if they want to learn more.
Yeah, you can definitely email us. I think we can also follow up with a few of those resources and send those out, but also on the PFCC Partners website, we have additional resources. I believe the interview guide is up there, and other information to help you structure what patient-family engagement can look like for your organizations. Thank you, Libby, for putting the website in the chat.
Excellent. Well, yes, we will send a follow-up email with the recording and the slides and all of those resources and our contact information. And never hesitate to reach out. We love to chat and listen. And I think I speak on behalf of the group when I say we always learn as much from you as you might learn from a conversation with us. So we love getting requests to talk more about this work, and really appreciate, as others have said, everything you're doing to tackle these tough challenges. So thanks so much, everyone. Have a wonderful afternoon, and I'm sure we'll be in touch with you all soon. Take care.
Yeah, thank you. Thank you, Barbara. Thank you, Laura. Appreciate you.